Good morning, co-chairs. I show 9 o'clock. I'd just like to make a couple announcements before we get started, if that's okay. I have Katie Bruins, who is the new Deputy Administrator here at Workers' Compensation with us today.
Good morning.
And I just wanted to let everybody know that conference room 260, the AC is out. So we are in the basement. So we will probably have all our meetings virtually. You are always welcome to attend, but virtual will probably be the best option. So I'm making that announcement at all our subcommittee meetings. All right, co-chair, over to you.
I think it's me today, right, Kim? Is that right? Okay. Good morning, everyone. So we are going to begin. Thank you all for joining the Subcommittee on Access to Care. As far as the agenda goes, it looks like we're going to review the scope statement and objectives first. Is that correct, Terry?
That's what I have. I think Bob is going to put it up on the screen for you, Emily.
Tremendous. So I have made some proposed changes I want to run through. And then just get everybody's input, and then get a little bit of approval, I guess, from Kim if this looks good and we can update them. Initially, we put up some objectives and a generalized scope statement to try and keep on task for this subcommittee. And with the couple of meetings that we've had, I think we can be a little bit more clear about what our objectives are. And so if you'll scroll down, because I don't think I have the ability to, all the way to the bottom just really quickly. Thank you so much. We originally had these sort of 4 objectives that were very, very generalized. This is just track changes at the moment because I want to make sure people understand what we're looking to change. And then if you would, Baba, like scroll back up, what we've done is sort of prioritize based on the conversations we've had here, what our true focus and objectives that we want to get through are. So we're really looking at assess barriers to provider participation, especially in rural areas. Part of that is going to be the invitation we have to various providers to give us their input on what it's like to work within the MCO system or what it's like to work sort of in general in the workers' compensation system, really trying to highlight the pain points so that we can make some recommendations, hopefully for some low-hanging fruit regarding rulemaking or process administrative tasks that might make that a little easier to entice some more providers. Also looking at in 3374, there was talk of expanding attending providership beyond the provider types that are currently within the system to try and improve generalized access. So we're going to talk to hopefully a variety of those providers as well and try and make some recommendations around attending physician status. And then any, additional pain points that we can find, we kind of try and want to map those within the system and then correspond hopefully some really meaningful solution recommendations, and so that it's really kind of clear what we have found out. So with that, if anybody has any questions, we're happy to answer. And if not, I'd like to, I don't know, I guess, Terry, do I move with 2 people? Do I move to adopt these changes?
No, as long as you and the
Okay.
co-chair. And co-chair, sorry, I haven't used your new name yet, Emily.
I know, it's weird.
This is available on the MLAC Subcommittee Access to Care website. So people can review it there. If they have any comments, they can let us know.
Okay, great.
All right.
All right, now I've got to move my screen. So with that, we are going to move to provider feedback, right?
Yes, and at this time we have Dr. Takeax and her billing manager, Joy, here. Oh, look, there they are. And they are going to present to us. Dr. Takeax is a medical arbiter. Sorry, I stumbled across that. And Joy is her billing manager. And they are going to provide us some information on their experience with the workers' compensation system.
Good morning.
So,
everybody okay?
yes.
Great. So I'm not just an arbiter. I think it helps if everybody understands where I'm coming from, because I think we have to make the whole system work and we have to be aware of the whole. So I'm a provider, I'm a physiatrist, and so I see predominantly my own patients, but it's not just work comp. I see regular patients, I do electrodiagnostic studies, and I also, what's important, I was on the OMA work comp committee for a long time. We don't even meet anymore. I do independent exams, I do arbiter exams, and I do consults. So it's an important thing to be aware that, I do all these things, and the important thing is that we have to make the system fair, and it's not. And if you are paying attention recently, it's not sustainable. And I think I have a unique perspective. I'm also an employer, and I've had I had one of my employees who had a work comp claim. So I pay for work comp and insurance, and I dealt with the return to work issues. So that's where I come from. And I think that you're all going to have to get really creative. This system is crumbling. And if you're not paying attention, you might not know, but the whole work comp system is not going to be able to last like this. And we all want it to last. So if you think about, I think you need to understand a little bit how it works when we see a patient or how we deal with getting them in, et cetera. So when a person first has their injury and they tell their employer they have an injury, the employers are pushing them to file, the 801 immediately. And sometimes it's not even a work-related thing, but the employer pushes them to do it. Even if they say, I just strained my knee, I have a knee problem from before, and they complete it. But then they can go, where are you going to get into? So you're going to go into an emergency room. Well, that really matters if you have a terrible injury, or you're going to go to urgent care. And urgent care, remember, is urgent care. It's not geared for long-term management. So then they go, and then they have to find a primary care. And I don't know how many times we in our clinic have heard, thank you so much for seeing me. I've been trying to find someone for 3 months to see me. This is in Portland. We have a lot of providers. It's worse rural. So but then they say, my primary care won't see me because I filed a work comp, so I can't see him. So nobody will see him. So that drives us all a little bit nuts because the person still needs care. It's not just a question of funding. So then I don't know if you are all aware, but occupational medicine is then what's moved into that. And that's a new specialty, certainly came on since I started practice. Occupational medicine is not a residency, it's a business model. And any type of physician can become an occupational medicine physician. I know surgeons who've done that, internists, primary care. Somebody who wants a job change, career might go occupational medicine. And you have to take some additional courses, not huge amounts. And if you want, you can sit for boards. But that should already tell you there's a problem. If there's a whole group that only treat occupational, so whether that fracture is the elbow or they tripped and fell at home, we've already got into different providers and different treatment modalities. And you'll find that people get treated a lot different in the work comp system than they do for the same exact injury somewhere else. And when I started practice, which was a long time ago, it was before we even had the managed care. Any willing provider could be the treating physician. And I think you should give some thought to that again, because when we started and they started the different plans like Liberty and Safe, we could be on it if we'd been providers and they thought that our treatment was reasonable. But now it's stuck to certain providers and there's no checks on the abuse. Everybody's afraid to check. There's some incredible abuse in the system and on all sides. And the system's been all about how we can generate the most money, not about patient care, getting them better, getting them back to work, looking to what their employer needs. So then the panels are way too small. People can't find, and I'm in Portland, they can't find who's on the panel. The panels are outdated. If you start to call through the list of providers on the panels, you'll find a huge number of them have had it. They don't take work comp anymore. So they go to their primary can't take care of it. Often it's a different insurance. The work comp, there's a huge delay if it's going to be accepted, which means the provider has to take the gamble that they're going to get paid because they might be on a different plan. So what of course happens with that, which is the downside, is people learn to scam the system. So you go to the urgent care, and some of the urgent cares, I've been impressed with the rural ones more because those urgent care providers, I get to look at IMEs and arbiters and see patients. Those providers work the urgent care. They're often primary care. They're more part of their community. They see the whole maybe a little bit more. But here we get mills. So where they'll send a person with a brand new injury, maybe a simple strain that just needs a rest for a couple weeks. They'll get PT, chiropractic, massage. They'll see the provider every month to fill out the paperwork. They're just kept off work, and the system goes until they've used up the limit that they can see. And then there used to be their attending at that clinic would take over, but now they dump them, the patients, and the patients then end up begging for care for those of us providers who feel morally obliged. And people who have had 4 6-month-old claims, we're going to have a low chance of success. People don't want the old claims. You can't get them into surgeries then. And so what happens then? The surgeons, they've given up. A lot of providers have just plain given up because the work comp system is everybody is manipulating everybody else. And it wasn't like that. So there's many good patients, but some will be manipulating for time off. Their employer will be manipulating to get them back, or there's great employers too. If you don't pay your bills quick enough to work comp, or you don't answer doctor phone calls, doctors are going to give up. You request MRIs and you don't get the answer. And it starts to tear physicians up morally. They want to take care of them. Patient can't cash pay because they have an open work comp claim. They can't use their regular insurance. And so the provider has to take a gamble. So what's really changed, and you all may or may not be aware of it, is certainly in cities that there's a few major providers. Almost no physicians are self-employed. So my era, we were mainly self-employed. And now most are employed by companies. So you're not talking to the doctor or the provider about getting on the panel. You're talking to the huge company for which they work. So in Portland, we have the OHSU Tuality Adventist is one group. We have Legacy Emmanuel, it's another group. We have the Providence group. We have Kaiser, and we have a few little stragglers. So all those big companies too, they're the providers and they're the insurance company. So of course, the more you do for a patient, the more you get paid. So they put a lot of pressure on the providers to really ramp the bill up, order plenty of tests from that location, and but they often don't let their primary care on. So they've decided it's a business model for them not to do primary care. Or you get the places like Kaiser, and Kaiser, as soon as you file a work comp, it's immediately in a totally different treatment group. You go through the occupational medicine department, and so if the person says, I have an old knee injury and now I've strained it at work, that's 2 different compartments, that's 2 different providers. And if you think about the business model, Kaiser makes money if they bill work comp. If they treat that same knee injury for regular insurance, they're going to lose money because they're the insurance company and the provider. So more and more the companies are the provider. Say Providence also, they're the provider, they're the insurance company. And the more they do for their regular patients, the less they make. The more they do for work comp and motor vehicle, the more they make. So I think as you want to get more providers, you're actually going to need to go through the companies themselves, um, and figure out a system. Then what's happened is the providers have burned out and they've had it. And I've already talked to 3 providers this year, excellent physicians who've had it, because it's so much work. And we get comments like, if you fill out the work comp return to work form, we can pay you for it. Well, I got a whole day of patients I have to keep up. I have to dictate. It doesn't help me that you tell me you pay for that. And so then what happens? Then people scam that one. So what I've been seeing happening is the doctors just say off work a month. That's really convenient. But what if their dominant hand is fine, their non-dominant is the injured? That's ridiculous. So, and then as soon as you just do this and the patient can't see the provider and they're off work, you've undermined the relationship of the patient, the employee to the employer. And that relationship is pretty important and shouldn't get damaged. And then the employer doesn't trust them. And then the employer works systems like maybe having them read policy and procedure manuals for 8 hours a day, trying to get them to leave. And you've ruined that relationship. And then the patient, of course, is not employable. So you need to get care. It needs to happen promptly, but you need to understand the finances behind it. So if you're one of these mill clinics, and there's more and more of them, they will do maybe chiropractic, acupuncture, massage, just recheck, send them back. And that's not helping the worker. That's not real care. And why are we doing things where a person strained a muscle and maybe they just need a rest and nothing done, and you're sending them out to strengthen that muscle? And I remember when I started practice, there were the stark agreements. You couldn't send to your own PT. I used to own Synergy Rehab, and you couldn't send your own. I'm not saying we shouldn't. I have a therapist here, and the reason he's here is I need him to do more sophisticated stuff. So the other thing that affects care, say if you're trying to get into a therapy, is if you have the PTs, and there are other groups too, they're seeing people many times a week, month after month, and there's no documented progress. When I started, you had to document that you were getting improved range of motion. There was a reason to do it. But you're getting no progress, then those PTs are totally booked up from the new real patients who need it. And there's an unholy alliance between the dysfunctional body-focused individuals who keep going to PT and stay off work versus those who are going to go if it helps, stop it if it doesn't, and getting in new people. So you're going to have to weed out the bad apples of providers. And we haven't been able to do that as physicians. We can turn people into our board of medical examiners for malpractice, but not for fiscal abuse. And it can take years to get them out. And the panels are no longer for the people who did a good job. So why not give some serious thought to just opening up your panels to any willing providers and then doing something if they abuse the system? Because the abuse of the system, everybody's afraid to get sued and get back on the panel, and you're going to have to deal with that at some level to get people in. And then we should get into some nuts and bolts, and Joy's also going to have here. I think we also have to talk about the monkeys, the elephant in the room. And one of the concepts is, and this is in regular insurance also, why are insurances selling policies where the need can't be met? So we have that in regular insurance too. So anybody who needs to, as an employer, they need to find an insurance who will then provide the care. But if there's not enough panels and people on the panel, they shouldn't be selling that. So if I'm a car dealer and I have 10 cars to sell, I shouldn't be selling 20. So if you don't have the providers, then you got to figure something else to do. And sometimes they do good things here. There's no psychiatrist, there's no psychologist. That we get the list. There's nobody on the panels. We go out a panel. There simply is nobody. We have a mental health crisis in Oregon and elsewhere. There aren't any providers. But we should then have a list that says none of these are taking providers. We have these endless lists that say who's on the plan, but they're not taking work comp, or they've got more than they can handle. Somebody needs to pare the list down so that we really have who will take providers. And then the other elephant in the room, and this we should spend some time on, is the system has really fallen apart since COVID. So it was bad before, but now it's really bad. So SAFE is probably the easiest to deal with. They're private, public, SAFE. There's some bad claim reps there also. SAFE will at least, and Joy will give you a lot of deals, mostly answer our calls and get back with us. You know, it's like if you want to schedule a patient, you can't find out what their accepted conditions are. You need to get an MRI. You can't find out if they can get it. You can't even get somebody to call and answer if you can get an MRI. Nobody will answer. They won't call back. They won't tell us that they've got things. And here's the thing that Sedgwick is the worst. And Sedgwick and Joy can tell you a lot more. And they need to at least acknowledge that when they're going to get back. And I don't know, they're followed by Liberty, Corvell, Gallagher Bassett is kind of a win and lose. And but we need to know, because if we don't get the answer, we have to treat this person. If you're not going to pay for it, then we got to talk to them. Who is? Do you want to do it anyway? Do you want to cash pay? Do you want to use your regular health insurance? Am I the right provider? But if they don't call back and don't tell you, and then it can often be that you've got no response for at least a month. And meanwhile, they're not back at work. You have no choice but to take them off work. You're in endless little notes that you have to fill out for everybody, and nothing's happening. And the employer isn't getting them back. I mean, they want them back, right? Or they need to replace them, or they need to do something about it. It further undermines the relationship between the employer and the employee. I mean, good employees are gold, and they're hard to come by. And you have to cooperate, employer and employee. And it all becomes adversarial. And I thought, if you hear what Joy, and other people don't know what Joy does. I mean, I think that's why your big institutions don't want to bother with work comp. You have to have lots of staff just for all these calls. Oh, I should add to that before Joy tells you. You call an orthopedic surgeon, you call a surgeon or a specialist, and you say, I need them to see this patient. And they say, I got to get approval. Maybe they're not on their Blue Cross plan, or they're on there. And so you might wait months to get that approval. Then they review the records. They decide if they're going to see them. We get records. I get it for physiatry or EMG. Then you get records and go, this isn't even the claim. And then you say no. So what are we doing? We're sending referrals to many, many doctors, all with the same specialty, hoping somebody will bite and see our patient. This is ridiculous. And then the patient comes in their recheck in a month, and it's, have you heard anything? No. Have I heard anything? And the exact same thing that I have in dealing with the insurer, and the patients are telling me the same thing. I've called my insurer. They don't answer. They don't answer my email. But you take a patient who then, maybe they have an attorney, and they call their claim rep independently, and they get a lecture about how they're not supposed to call. They're supposed to go through the attorney. Those calls get answered. Why aren't they calling the patient and answering their questions? Why aren't they calling us? And those of us who work all day long, and we're working. We are here, and we and the patients think some of these people and some of these companies are not even maybe working. I know people are working from home. I think some are really working from home, but I think some people are just calling when it feels convenient and doing their second life, and it doesn't work. And I want Joy to then give you a presentation and try to explain what goes through to try to get people taken care of. And it's a moral question, because we have other patients, we have regular insurance, we have motor vehicle, but your system is untenable, and it's going to collapse on itself unless you get some creative thinking.
Hello, everyone. Most of you maybe already know me. I've been here with Dr. Takex for 19 years now. And like Dr. Jones said, it has been very, very difficult, and somebody has to, get creative to get something done. Because a lot of insurance companies, adjusters, they're still working from home. And like Dr. Jones said, you're working from home, but are you really working? Because we can tell who's really working. And, when we call these adjusters, when I talk to them, most of them, you hear, in the background, you hear all other different kinds of noises. So it's great, when you're working from home, but it would be nice to actually, be working. And we hear a lot of frustrations from our patients. They are very great when we can get them in. Because they're like, well, do you know how can I get hold of my adjusters? Because I can't get hold of them, and so, we try to do everything we can. But it's very difficult out there to get any answers from insurance companies. Like Dr. Jones said, safe is the easiest, yes, to work with. But, we do have to work with other insurance companies also. And again, I'm not sure how long this is going to last, but after COVID, things have been really, really worse. And it's just, you just don't get any responses from, some of the insurance companies and adjusters. Doesn't matter. I mean, yeah, it's great, the work on board, they want us to let them know when the adjusters are not calling, but, why only us, why do we have to, okay, we call the adjusters, and now, okay, we have to keep track of that, and then let the work board know. I mean, why us? We don't have all the time. We're trying to treat the patient. The doctors are trying to treat the patients, get the treatment approved. But, I see all these meetings, I go to all these meetings, and I don't know if really anything is getting done, or is everybody just meeting, but I hope something gets done here pretty soon, or somebody, should start getting creative if they want the work comp system to work. So
she was even explaining to me before, I mean, some of these companies, you can call 5 or 6 times and you leave messages. We leave emails, that's the MAs are the front. They don't even acknowledge they got it, so we have to keep sending it. You gave me a great example of one that you called 5 times and they finally answered. You might want to tell them.
Yes, and somebody, finally answered, and then I was talking to them, and then I had a question for another person in the same office or same insurance company, and I asked them, well, do you know if they're there in the office? And the person goes, oh, I haven't seen that person in the last 4 years. I don't know where they are. So it's just like, okay. Those are the, kinds of things we get to hear. So who knows what's happening out there after COVID, but it's pretty interesting.
And you wonder why no provider wants to deal with this? And then if you just become a mill and you just see them, you can generate all your money, see them 5, 6 times a week quickly. And maybe you start by thinking you're idealist, and then you go, it won't work. And so I got to generate income to keep my clinic alive. And if you're not ruled by morality, you're going to find a way to do it. And yeah, but she even gave me an example. They gave me an example of this week of an insurance company stopping payment for an arbiter. Like, really? So then my staff has to spend like 30 minutes trying to clarify it up that you actually have to pay these things.
And the insurance companies, themselves, they are frustrated among, their bill review and them. So if they can't work with their bill review people, how do they expect us to, work with them? It's very frustrating out there. It's recently for the last year or two, I mean.
I don't know if you're allowed to do it legally, but I think one of you should pretend you're a patient, or maybe even be a fake patient, and go try to get an appointment. I mean, really experience it. Then try to call an adjuster, and or try to get through. I mean, even adjuster, you want to talk to. The return to work specialist used to be great. I would call them up and say, could you please help be a go-between me and the employer? This is what I think they could do. Could you work it out? Could we make it work? And but you can't get anybody to call back. It's the whole system. I mean, we have this as a culture as a whole. It's all about how much money can I make, as opposed to can I do a really good job and get paid for my work. So if your patient gets well quicker, you'll be paid less. So the really efficient PTs, I have a therapist, and I mean, we do maybe a couple months, maybe once a week, rarely twice a week, but I correct it if the movement needs correction. And but if you're just like endlessly treating and it's not working, I think somebody needs to go inside in the organization and really see how it goes. And then the other thing that burns out providers is maybe there needs to be, I don't know, an ombudsman, that's only, the ombudsman is a waste of time, by the way. We always hand out the cards, but it's a total waste. Try calling your ombudsman sometime. And, but somebody who maybe can make the system work so that, endlessly, it doesn't burden the providers. Providers, we just want to be doctors. Our success is if the patient gets well and goes back to work. My success is not how much money I make. My success is if they can do their work in the world. So it's wrong. The whole system is about as many patients an hour as you can see, generate as much bill as you can, and somehow you've got to change the incentive system. Reward people. Oh, you probably know this. There's one of the clinics, you'll know it if you read the reports, who the providers are all told they have to give a % improvement at every visit. Are they 80% better, 70%? That's pretty silly, right? Try rating that. And that's a requirement of the providers, and the numbers are to be made to look going up. And then at the end, the claim should be closed. That's silly. That's ridiculous medicine. So the goal should be that we're taking care of the worker and their employer so that they can get back to work. It's not a money-making, right now it's all about the middlemen. It's not about somebody. We should dust off the mission statement and make sure you're really following it. Instead of everybody's going off to their little private separate issues of their clinic or whatever. We and you guys have to look at the whole. I don't know. I hope that helps you know. I mean, it's really frustrating, and you're going to have a hard time unless you change the system, getting real good doctors. I should just tell you, the surgeons have given up. So surgeons want to treat people, they want to get them better, and then they want to tell them when you can go back to work. But they can't stand how much you're nickeling and diming them. So they get an attending who's different. And the attending is usually somebody who will rubber stamp. And when I read IMEs, I don't think often the people rubber stamping are reading the orthopedic recommendation. If I'm an attending for a claim, I read what the orthopedist says and I follow their guidelines. But why have you done that? Why does that happen to all our surgeons? Why can't you go back to your surgeon who does surgery to check if your hardware needs to come out? No, we attendings have to scramble and beg an orthopedic surgeon to please see them because we have a connection to this doctor, and will they take up the hardware? And why can't you make it so that a previous provider for this patient before they got enrolled or got shifted insurance, that they can't go back? And I've been told by managed care, well, we'll temporary credential them. Nobody wants to waste time being temporary credentialed. We got plenty of business. There's a doctor shortage in Oregon. People are waiting months for the simplest things. I mean, if we don't have time to do all that, we'll deal with a different patient population. So I don't mean to just complain. It's just this system's going to crumble unless you get creative and imaginative and do things in a really new way.
Dr. Takeax, we have a couple questions. Would you mind answering a couple questions?
That's right.
Co-chairs, Co-chair Cronin, do you want to go first? I'm sorry, I didn't see who raised their hand first.
Kim was first.
Oh,
Kim was
thank
first? Okay.
you. Let's see, get myself off mute. Thank you, Dr. Takeax and Joy. That was very enlightening. Yeah, and a little sobering. My question is, this subcommittee really came about because there was a proposed House Bill 3374 that SAFE presented. And the gist of that bill was for SAFE to become like a managed care organization, if I understand it correctly. So in your presentation, you did say, SAFE was, the easiest to work with. And I just start thinking, it's like, well, maybe that would be a good direction. That is to have SAFE become a managed care organization, and they could process these injured workers better. There would be more efficiencies. They seem, they understand injured workers. They understand the importance of getting them back to work. I don't know what do you think about that? I don't know if you're familiar with that, what that House bill was, but I'd just like to hear what your impression is about having them do something like that.
So I have mixed feelings about that. So I'm in private practice. I run my own business. I had a multidisciplinary pain clinic, and I think when things get too big, they get corrupt, and that's always a risk. And that you can't legislate morality, which is what everybody's trying to do, and so it might be fine if they're managed care. But I don't think they should be managed care of all their plans, because that will then make them start to cheat too. So there's a hard thing with managed care in that SAFE has a managed care organization, and we have to get approval, and then the claimant will often not unless they go through managed care. And then there's a delay, and so there's a lot of time loss not being it. Managed care used to be so they could control the panel of providers, but their panels are too small. And it used to be so it could be efficient. But managed care is losing its way also, because managed care seems to become an issue for cost containment alone, as opposed to, I'd like to call it the managed care and say, I really need an ophthalmologist. Find one for me. Don't make me go through all these calls. Manage the claim. So I have really mixed feelings about them. They're good. Maybe they're good because don't own the whole piece of the pie. And, I'm not a big fan of everything being government run. So I think I'm not really sure. It could be helpful, but they would need some significant checks. Maybe they should be managed care for other providers. That would be a good one. Make them managed care, but only managed care because they have the system for insurances that they're not. But that would probably give them insider trading understanding. But I don't know. What do you think, Joy?
Yeah, I agree with everything Dr. Jones said. Yes, it's a little bit,
Thank you. I appreciate that feedback.
I even thought, well, what if you, and I can see why it wouldn't work. What if you made a clinic in the commercial areas, in the big areas, and you said, this is Safe's clinic, right? And anybody can just come here and we'll make sure they get seen and et cetera, et cetera. Well, that's going to get corrupt pretty quick. So I think that we all need checks and balances, and we all need competition. But if you let them be managed care, you better have checks and balances. I think CareMart was a great MCO. I mean, we all liked them. They put checks and balances, but of course they're connected with Legacy. Legacy didn't want anything more to do with the system. They would call up and talk to us. They would meet with us. They did push, but we could push back. Some of the other managed care are just, they bully and push those of us who are cost efficient because they think they can save money on us. And then they don't stop other abuse. You'd really need to look at follow the money trail.
Thank you.
Yeah.
Dr. Cronin, you had a question?
I do. Sorry, I was feverishly typing. So earlier you mentioned the need to change the incentive system, which makes sense, right? We're looking at quantity or quality over volume or quantity. But I'm just curious, in your perspective and having worked in the system for quite some time, what does meaningful metrics on progress look like for you? Like, how would you view when you're talking about checks and balances, when you're talking about a worker going through the system and needing to show improvement, which makes sense to me as a nurse, for the value of looking at a care plan and doing modalities and interventions that are meaningful and seeing progress, right? I'm used to charting to progression every single visit, every single time I interact with that patient. But you mentioned that became like a silly sort of metric around just proving it for the sake of proving it, just putting in a number for the sake of a number. So what would meaningful metrics look like for you for progress when you're talking about caring for an individual in the system?
The effect, not just the complaint. So are they getting better range of motion? Are they getting better strength? Have they gone back to work light duty? Are they doing their hobbies? Are they doing things? I don't know if you all treat other systems, but say how the motor vehicle insurance goes. So if you have a motor vehicle accident, some people don't carry much insurance. So one of the downsides of that one is they go to the ER and they'll often use up their whole bill. They'll do all scans of everything and use the whole thing up. But with motor vehicle, we treat things. There's a certain amount of money. There's the PIP, the personal injury protection. When it runs out at a year, you have to file, or 2 years go to court. But the system it's geared to make people get back to work, right? And so we don't have that. Apparently, you could look at Colorado. Apparently, Colorado has a different way it does it. It would be interesting for you to look at how Colorado does their work comp. And what else is hard about the metrics is that sometimes when the various ones of us get together for panel arbiters, we talk about that, all PT is not the same thing, right? There's effective or not effective. PT doesn't work. It doesn't mean it doesn't work. It doesn't mean like if I give a person a medicine, it doesn't work. It doesn't mean all medicines don't work. So if something's not working of anything, stop it. Like, I'm extremely good at osteopathic manipulation. I taught it in the medical school. But if it's not working, I stop it, And I think you have to judge it by the outcome. And it's not just about the mechanical factor. Those of us who do a lot of work comp, it's about the soul quality. I mean, if you're a good provider, you help a person cope, you help them understand what's injury, not injury, you help them understand fear of injury, how to push through it. So are they getting on with life? I would say the best way to look at it is, are they getting on with life? Are they able to do more? And everybody's, the cunning and the chart notes, I've watched this now that I do in IMEs. They've intentionally now they're leaving off all the relevant past medical history. I wish when I was the attending, I had half of the information I have as an IME. So they leave off, they just say no relevant history. Well, they might have had 10 knee surgeries before and they're seeing me for a knee contusion and I never knew it, right? And the notes, they must be billing that way. Really, do we really believe if they have a meniscal tear, they're checking their ENT and they're listening to their heart and their lungs? Give me a break. They're not. So maybe the way to do it is ask the patient, are you getting better? Although the hysterics will always, they'll say they're getting better to make their doctors happy sometimes and just stay off work. So it gets a bit complicated.
Sure. Thank you.
Yeah. Maybe a thing to look at would be maybe there'd be criteria. I'm just playing with this idea, right? And you'd have to think it through about, and not these silly guidelines that are put out, the DRG or whatever, but what's a typical return to work? A strain is a pulled muscle. If we with IMEs, if they're not well in 4 months, it's not a strain. What is it? Is it a herniated disc? Is it they won't do their exercises? Is it their soul pain is so great? Maybe there should be, and if it's complicated because they got an underlying disc, maybe there should be, this is the limit of what we'll pay providers. Use it wisely. When it runs out, it's out. Yeah, but that would require quite a bit of thought. But that has to be seeing way beyond just bean counting. Like even when we meet with one of the companies, they pull out our statistics. How good are we at turning in our pre-certs and our return to work forms? Come on, like let's meet and try to figure out how to do this efficiently, faster. Don't waste my time. Somebody else can do that. It doesn't need me.
Thank you.
Mm-hmm. Did you have to add?
Yeah.
Keep your idealism. We got to have it or this system's going to pull us all under.
I was just going to ask if there were any other questions. Thanks.
Thank you. Sorry. Hi, Thais Lomax with Sedgwick. Joy, we talk regular, so I'm a little on your comments earlier. We hear your frustration. The processors in the state also have great frustrations with the two-tiered system that there is, especially when it comes to medical care, and those that are enrolled in MCOs and those that are not. So I would maybe keep in mind that that's part of the complication and part of the frustration, both with the doctors, the injured workers, and those of us that are trying to process and handle and manage these claims. Examiners in the state are barred by law from directing care. So when we're getting questions at the examiner level saying, hey, am I authorized to do X, Y, and Z? More often than not, they're not allowed to say yes or no. If there's an MCO involved, they can say, you need to check your MCO contract. But if there's not an MCO involved, they're not allowed to say, I'm going to say yes to your PT plan. They can say, your attending physician can submit that plan to us and we will pay what's reasonable and necessary per their direction. So it gets evolutionarily more complicated, and then attorneys get involved and there are disputes at the MRT and decisions from one judge versus a different judge. It's all just overly complex, I think, on multiple levels. So what can be done to simplify the communication, to simplify the rules about what can and can't be done, and to make sure that people who need to get their appointments scheduled can just get them scheduled. They can say, hey, this is what's accepted. Is there an MCO, yes or no? And what can we do to get people in? That's I think, what everybody involved really wants.
Can I ask a question back?
Absolutely.
I first have a comment that the other insurers don't work that way. And so you can find out what's legal that they do that you can't. But I have two questions. One is, what are you going to do to fix it? And my second question is Sedgwick insuring more people than you're capable of handling?
Well, to one point, Sedgwick is not an insurer. We're a third-party administrator. We handle the second largest group of claims in the state of Oregon currently, as far as work comp goes within the state. And we have people who are working 10 and 11-hour days trying to keep up on all of the different pieces that are involved in those claims.
Do you have too many in your plan to be able to manage?
No. We have some outages and we're working on staffing, but training new examiners is complicated. And there has been a lot of burnout. And I think anybody who is managing adjusters, not just in Oregon, but especially in Oregon, examiner burnout, especially since COVID, is a big thing. And we've lost a lot of really good examiners, and trying to train new people, it takes time.
But we providers and the patients don't have time. So we have to find a different solution.
And I understand. And that's why I think overall, I think everybody would agree that simplifying the system would be a great thing. If you were able to see a patient walk in and they say, here's my notice of acceptance, can you schedule me? And you knew exactly what to do and that things would be done, that would be a lot easier than this back and forth, than these loops that we're getting into, and orthopedic offices that are insisting on getting authorization before seeing someone, where I don't know until you see them, you know? So what can we do to fix that?
Maybe everybody should be covered by regular insurance and then switched over when it's accepted or something. I mean, that means people who don't have insurance don't get coverage, and that's why that doesn't work that way.
Yeah, no, absolutely.
Thank you so much. That's why we're here, trying to problem solve.
Yeah, I appreciate it. I wanna give Keith space.
Thank you, co-chairs. I just want to thank Dr. Tickax for the very complete overview of what injured workers are facing in this system. It's heartbreaking to talk to these folks day in, day out. I mean, it is a second-class health system. It's extremely limited. Things that resonated with me is the fact that we need to start by talking to these healthcare conglomerates that won't allow their mid-level providers to have anything to do with the workers' comp claim. I mean, all of these claims are being funneled to the only providers who will take them, which is occupational health. In our experience, I practice in Eugene. I've practiced in Eugene for 22 years representing injured workers. I have seen over the course of that 22 years exactly what Dr. Tickax has described, which is that it used to be family doctors were independent, one, which most of them no longer are, but also that many of the local mid-level providers were not only on the list, but willing to take workers' comp patients. And that has slowly declined to the point where my clients never ever come in and tell me anything, but I talked to my primary and they said, go to occupational health. Most providers in Eugene don't even know that there's at least 2 outfits in the town of Eugene, one with 2 or 3 providers, but at least 2 outfits in the town of Eugene that do workers' comp. One is occupational health. So, you know, you're not supposed to direct care, but I always tell my clients every road leads to occupational health. Any other provider you see in the system knows they don't do it, but occupational health does. So we've seen a concentration of providers. That means if workers want second opinions, if the occupational health is really the only outfit that will see them, they can't even get another doctor's thoughts on their case, on their situation, on their treatment plan. So I echo, and as soon as Ola, you know, kind of had the time to weigh into this presentation, I was going to say that I think we don't start with a new MCO or consolidation of MCOs. I think we start with the executives because my wife's a nurse practitioner. She works for Peace Health. They won't let their mid-level providers do these cases. They're huge. They're basically the only hospital in town. Now, their surgeons will get involved sometimes and their specialists, but not as attending, you know, as long-term attending physicians. Talk to them. Why, you know, have they expressed desire for more MCO involvement? Is that what the barrier is for them? I doubt it. But let's find out what is the barrier for them, because they are the ones really with the numbers that can unlock some actual change here. It's not going to happen with 1 or 2 providers. And I kind of wonder if MCOs are, you know, an ideal part of the system. What has been done in that regard to recruit large numbers of providers that reside in these larger organizations? I mean, I hope something before we just create another MCO. Why can't that be done outside of having an MCO? You know, one of the things that also resonated with me was Dr. Tickax's kind of ranking of insurer responsiveness. I felt like that was 100% spot on from what I've seen and talked to with my clients over the past 22 years. We have the same experience. In fact, often they come to me because they've called their adjuster a million times, sent emails, can't get any response. So they say, I need somebody to cut through this. And then sometimes we go for weeks and weeks and weeks. Adjuster changes, nobody tells us. The doctor sending, I just have a client right now where the insurer or processor changed claim people. And I said, I finally got the provider's email that they had been sending to the claim processor. So I at least had a paper trail. A lot of times this stuff happens with phone calls. And the first thing I tell my client, I need to see, can you get the person's email? Can we set up a 3-person email with the adjuster to find out what the problem is? I cannot believe that the second biggest handler of claims in the Oregon insurance market can't pre-authorize because they can't direct care. the whole system obligates the insurer to tell the doctors what they will and won't cover. How can a doctor's just supposed to take a wing and a prayer every time they submit a bill? Is that how doctors, I'll ask Dr. Tickax the question after I'm done. Is that how doctors operate with private insurance, that they just send off a bill and maybe we get paid, maybe we don't? I wouldn't do that as a doctor. That sounds insane. If the comp system is the only system where doctors have to sign on for that, that seems like the pinch point to me. If the doctor can't get even a response, I mean, I hear what Sedgwick is saying about turnover and things like that. I did not hear an answer as to whether there were too many claims under the book of business. If people are working 12 hours and can't respond to doctors' inquiries and requests for pre-authorization, I mean, I didn't hear a clear no. I mean, it tells me yes. So, I mean, I guess someone kind of convinced me otherwise. But this is the processor that the state of Oregon, throw a little shade here, has selected to handle all the non-complying employer claims. So our vulnerable workers whose employers have already violated the law, they get sent to the company that won't get back to the doctors so they can get their medical care. And I can't wait to hear the response here. I'm sorry, I've talked to these injured workers and seen what they've gone to for 22 years. And I finally today seen somebody other than OTLA stand up and explain what's going on out there and where the problems lie. And I mean, it kind of fires me up. It makes me want to cry. I mean, I've seen these people go on and tell me all I want to do is get back to work. All I want to do is get the MRI to figure out if I need surgery so I can get this treated. And I mean, I know there's delays outside in the broader healthcare system, but it is nothing like the back and forth and nickel and diming that you see in the comp system. I don't know how to fix that. We talk amongst ourselves at OLA, deeply troubled by this whole thing. I don't know how we fix the level of acrimony in the system, but it's gotten worse and worse and worse and worse. The cost containment is all it's about, and decreasing premiums year after year, and what's lost in the process. That's all I have. Is that how you operate it outside the comp system, that you just have to take a hope that you might get paid in the claim?
Well, I'm a private clinic, so I can choose who I choose to treat for free. And but that should be my choice, not the insurance's. And but I couldn't survive if I did that except on a rare basis. And but otherwise we know they've investigated before. Joy has looked up, or we have other people who do more of the regular insurance, but they've looked up what's their benefits, you know, how much coverage they have for PT, can they get osteopathic manipulation? Can I do an EMG? What is their coverage? We know their coverage going in. And so if they don't have coverage for what they want to see me for, we then bring it to their consciousness. Like, you don't have coverage for this. Would you like to cash pay, or would you like to find another provider? And sometimes people show up here for the nerve studies, and that's with regular insurance, and we say we don't have it. And I tell you, a lot of times people are cash paying because we're not a clinic that takes Medicare, because we just can't make it on Medicare. You have to be a huge place to do Medicare. But many people cash pay me for nerve studies. Why? Because it's 6 months anywhere else. They got a surgery pending. This is regular insurance. And so they asked me to do it. And then I do the nerve studies, and periodically my staff will even tell me, this isn't covered yet. And I'll say, I have to take a chance because this person has radiculopathy and they can't lose that limb. So I'll gamble, but we gamble a lot and we lose money. And I mean, we have a business and it's good, but I could make many times more if I was immoral, but we have to make it work. But so does everybody else too. If a system doesn't work, make it work, figure out a way, get creative, put our heads together. It can't be about greed in the middleman. Just can't be.
What can I please say one more thing? Two solutions. One thing that we've been asking for years is that we have some deadlines and some timelines for responses to pre-authorization requests. Gradually, we've gotten that for therapy or for diagnostic studies. We finally were able to get there to be a timeline for the adjuster, a deadline for the adjuster to respond after the MCO has approved something and tell the provider whether they'll actually do it or not. We pointed out that once the MCO is involved, all of the timelines and deadlines get suspended. And the worker, I told my clients for years, you're just kind of in MCO land, you know, the rules don't apply. We don't get to see the contract, and the rules don't apply that are written in the actual law.
But
So
that's even worse.
we'd like to see there be a streamlined process. We'd like there, I would personally like there to be a general email or fax number or an email for every adjuster that providers can send these things to, so that they're not making verbal requests and we're not getting a million voicemails playing phone tag back and forth. And I'd like there to be some deadlines for responding to those requests, or maybe the bill just has to be paid if you can show you made the request and it was ignored. I mean, maybe the default is the treatment happens and the bill gets paid. And the exception is that, you know, that maybe there's some exception to that. If the provider or the processor can prove that they legitimately didn't get the request, or, you know, some other legitimate reason for not responding within the timeline. I mean, the treatment
Keith,
has to go forward.
I'm sorry to interrupt, but to that point, that is where we are right now with those responses saying this is what's accepted or what's under investigation. There is or is not an MCO, and we'll pay for the diagnostics and the reasonable treatment plan for that condition from the attending physician. So when they're asking, is the PT okay? Did the AP sign off on it? And is it for the condition we're looking at? Yes, we will.
That's
Is
not
it
what
a diagnostic
provider,
that's reasonable and
okay.
necessary? Yes, we will. So I'm sorry if there was a little misunderstanding in that earlier. But we would 100% agree. All of this needs to be simplified. The communication, the assurance to the doctors on what is or is not covered, every piece, absolutely. And our goal, as yours is, and I've been, you know, I started out as an adjuster in 1999. Taking care of people, getting them back to work, getting them through the system has been my goal for decades now. And I supervise that team that handles those state claims that you were referencing. And they work very, very hard to get those people back into the system, back into working as best we can, which is why we have that contract. I think we all agree the system is definitely broken, and it's broken on all sides. So what can we as this committee do to brainstorm some solutions to take it from this 2 or 3 tiered system to something that works for the providers, for the injured workers, and for the companies trying to coordinate it all?
I want to comment to Keith's comment. There's game playing with that one too. So the game playing is, I think the more you stall, the less you have to pay for. So we go and we ask for pre-cert. We ask for pre-cert. And so some of the companies, and they then finally get around to saying, okay, you can have your therapeutic exercise, or we can do the ultrasound or whatever. But by the time so I've asked for, say, maybe I've asked for treatment in early June. For the whole month of June, I've sent once a week. So the last week in June, and this happens to PTs too, you get the notice, we'll approve it. But then the dates are off. So we can't just move that to the next month. No, we got to send it all again for new dates or call. So they've learned to game that one too.
So, Dr. Tegax, can I ask a question? Is that an issue because of something we do, the workers' comp system? Is it the insurer? Is it the TPA? Is it
MCO?
CO? Okay.
Talking about the MCO.
It could be the MCO, but it can also, yeah, she's got a good point. Yeah.
MCO.
Yes, just sit back sometimes and look at claims or something and say, does this really make sense? Yeah.
Thank you. We are a touch over time on that agenda item. I appreciate the conversation so much. I'm feverishly taking notes. This is super valuable to have this dialogue. I know it's a little bit difficult to do so. We have many people at different sides of the table. It does sound like, the intention is to create solutions. And so just to remind everybody of that fact that like we need to hear the uncomfortable things to be able to look at some of the core of the problem and then hopefully come up with some, like you said, creative solutions, which is obviously our intention in being a part of this. So I lost my agenda, Terry. No, there it is. So we are going to move to, if we're ready, Terry, for the data report.
Yes, I just wanted to take a second to thank you, Dr. Take-Ax and Joy. We appreciate your presentation. I know your time is very valuable. This has been very insightful. We thank you everybody for participating. Like Co-Chair Cronin said, these are the conversations that we need to have so we can work on. Not only was the subcommittee came out of the legislation, like Co-Chair Schlessinger said, but these are the conversations that we want to have. And like I said, I think I have 10 pages of notes right now. So exactly what we said, we want to have these conversations and figure out, that's why I was asking, is it whose issue is it that has to redo the PT or whatever, so that we can have these conversations. Appreciate you so much.
You need Joy and I anymore?
I'll stay.
Joy will stay. I'm gonna sign off and go see patients.
Okay, appreciate you so much. Thank you. Okay, yes, and I believe that Raphael and Kelly, are you here? Are you ready? I believe so.
Yep, we are here. Hello.
Right, okay, I think we have to give permission to share, Kelly. Just a second.
Okay.
I do request it. That's what you requested. Request permission, Kelly. And
Oh.
Sorry. Now, do I do it or? Oh, there you go. We're all good.
Okay, perfect.
Now we're gonna talk about providers.
All right. Well, thank you, everyone. Good morning. Good morning to co-chairs and members of the committee. And thank you for having us present. Our conversation might be a little less robust than what was just had, but that was fantastic information for us to have as researchers. So we do appreciate it. But for the record, my name is Kelly Barushko. I'm the senior economist with the research unit here at DCBS. And I have with me today Raphael. Hope you're here. He might be still working on his sound. So Raphael Robles will be here. I will be starting off the presentation. And when he comes in, I'll have him introduce himself before he starts speaking. But we are here today to present some data on the Oregon workers' compensation medical care landscape as it relates to worker access to medical care. And there we go. So to get us oriented, I'll go over just a little bit of background information on the topic and provide an overview of the data we used in this analysis. Then I'll move into the analysis on first emergency evaluation and management visits, which is also known as the first office visit for claimants, including on a number of claims, provider types, and length of time to first visit. And after that, I'll turn it over to Raphael to discuss medical provider supply and demand, both in the workers' comp space and in Oregon more generally. Raphael will then finish up with some key takeaways from the research, highlight a few facts that might help explain some of the trends that we found as well. So first I'll go over a little bit about the DCBS data that we are sampling and some of the other data sources that we'll reference throughout the presentation. We do have a slide that has all of our reference notes on it as well if anybody needs to access those later. So for this presentation, we are focusing on data from 2010 to 2024. And we did select 2010 as a natural reference point because we did find that this topic of access to care was studied at least once before in 2011. So we wanted to make sure that we showed as much time as we could to see if there had been any meaningful changes since this was last studied. So the categories of providers we consider are based on WCD's provider matrix that Administrator Matt West shared a few weeks ago. They are referenced in OARs 436-009 and 010. If anybody needs to reference those as well, I'll specify them a little bit more detail later. And then to further categorize provider types, we used the publicly available data reported to the National Provider Identifier Registry, or NPI registry, and sourced our claims data from the medical bills and services reported to DCBS. Just as a note though, since both of these sources rely on self-reported data, any provider or claim that isn't reported, like some non-disabling claims, for example, are not captured in our analysis. So there are, some small gaps in what we do have, but it is as robust as we're able to get. And then finally, where we can, we do try to include an analysis on differences between urban and rural areas, because that has been identified as a potential source of some access to care issues where rural areas and claimants in rural areas might not be able to get to doctors and providers as quickly as they might like. So we wanted to see if that was in fact the case, as we could confirm with data. We do use OHSU's area designations provided by the Office of Rural Health to make these distinctions. So this map here is what shows the area designations. The yellow circles highlight urban areas. Sorry, trying to make that thing go away. There we go. The yellow circles highlight urban areas by zip code. So in 2024, these areas represented about 65% of the Oregon population. The light green areas represent rural areas by zip code and made up about 33% of the population in 2024. And then finally, our frontier areas, which are split by county rather than zip code. These ones are shown in the dark green areas. And for our analysis, because the frontier areas make up only 2% of the Oregon population, we combined those with the rural areas to create just one general rural category. So moving into our analysis, the first thing that we looked at was non-emergency evaluation and management appointments for workers' compensation claimants. These appointments, like I mentioned before, are considered the first office visits where claimants are evaluated after an injury and don't include appointments coded as urgent care or emergency room visits. And based on the workers' compensation provider matrix I referenced earlier, we also limit this analysis to chiropractors, nurse practitioners, physician associates, and MDs with emergency medicine, family, or general practice, internal medicine specialties, along with those without a defined specialty from the NPI registry. We start off looking at general trends within the data for these first non-emergency E&M appointments. In the left-hand graph, which shows the number of claims by provider type between 2010 and 2024, we see that chiropractors and emergency medicine providers see the fewest number of claims overall. We can also see that non-emergency MDs are seeing fewer over time, while nurse practitioners and physician associates are seeing more. And then over on the right-hand graph, which shows the number of providers by type, we see that there are a large number of chiropractors relative to the number of claims that they see. We can also see that generally the number of claims that each provider type sees trends with the number of providers seeing claimants at that first office visit within the state of Oregon. So for example, as the number of claims seen by nurse practitioners increased from 2010 to 2024, the total number of providers also increased. And we looked at the ratio of claims per provider and noticed that the most sizable change is with emergency medicine providers, where each provider saw just over 15 claimants in 2024, down from a high of about 38 in 2013. But as we saw on the last slide, this change is likely due to just the low number of emergency medicine specialists that are seeing claimants at an office visit setting. For the other provider types, we see less drastic changes. There was a slight decrease for chiropractors and all other MDs within the 15-year time span that we looked at, but a slight increase in claims per provider for nurse practitioners and physician associates. And because non-emergency MDs, nurse practitioners, and physician associates make up the majority of providers claimants see first, we decided to break those out by provider type to look more closely at their share of claimants seen and how they're changing over time. In this comparison, we see that although MDs, NPs, and PAs all saw about 14 claims per provider in 2010, that ratio spiked for physician associates in 2018 with 19.3 claims per provider, and for nurse practitioners in 2022 with 21.9 claims per provider. During that same time span, we see that non-emergency MDs are seeing proportionally fewer claimants at their first office visit in 2024 than they did in 2010. And then as compared to all medical providers, and this, the trend line with the light blue dotted line, includes all medical providers, including chiropractors and other non-emergency MDs that we didn't actually highlight in this analysis. But comparing it to that, nurse practitioners and physician associates are seeing an increasing number of claimants, while MDs are seeing fewer, which is closer to that all provider ratio at 12.7 claimants per provider. The next thing that we explored was the time it takes for claimants to see their first provider in office. We chose to look at each provider type and the percent of claimants that they see within 3, 14, and 30 days after the date of injury. First up, we looked at non-emergency medical doctors, where we see a dip in claimants seen within 3 days after injury, right around the COVID-19 pandemic. Between 2010 and 2022, non-emergency MDs saw about 54% of their patients within 3 days after injury, but saw about 60% in 2024, the highest level between 2010 and 2024. So we do think that this is indicative of the pandemic restrictions that likely resulted in folks waiting longer to visit doctors. And within 30 days of injury, MDs have reliably seen about 93% of claimants within the last 15 years. Emergency medicine providers saw an increase in the percent of claimants they saw within 3 days of injury from 2019 to 2023. There's also more variability for these providers than the others. Some of this is likely due to pandemic restrictions. Emergency medicine doctors were probably a little more busy during the pandemic than other providers were. But it's also likely due to the low number of providers in this specialty seeing claimants at that first office visit. Since 2010, chiropractors have seen a significant decrease in the number of claimants seen within 3 days of injury, with a 15-year low of 34% in 2024. This is despite a slight decrease in the number of claims each provider sees over the same time frame. And they're also seeing slightly fewer claimants within the 14 and 30-day periods that we explored. Physician associates are seeing roughly the same number of claimants within 30 days of injury at the first office visit, but fewer earlier on in the process. So in 2018, physician associates saw about 71% of claimants within 3 days after injury. But in 2024, they hit their historical low, seeing only 64% within 3 days. But on the other hand, within 30 days, they've consistently been seeing 95% of patients in that time frame since 2010. So this means that in addition to seeing more claimants per provider, as we saw a few slides ago, physician associates are seeing more claimants within a shorter time frame post-injury. The same thing is true for nurse practitioners. In 2018, nurse practitioners saw just over 62% of claimants within 3 days of injury, but that number dropped to 55% in 2023 before rebounding a bit in 2024. Nurse practitioners also saw fewer claims within 14 days, going from 88% in 2010 to a low of 83% in 2023 before again rebounding a bit in 2024. And then finally, we broke out some of this data based on rural and urban areas to see if those patterns were isolated to one geographic group or were more widespread. What we did find was that rural and urban areas had similar trends for MDs and chiropractors, where MDs saw noticeable changes around the pandemic, and chiropractors are generally seeing slightly fewer patients, and they're seeing them slower than before. For physician associates and nurse practitioners, what we found was that rural areas were actually maintaining their trends of seeing patients faster, better than urban areas in their first time or their time to first provider visit. And then with that, I'll turn it over to Raphael. Hopefully his audio is working at this point in time. To discuss some of the broader supply and demand trends that we're seeing across Oregon.
All right, let's see. Is my audio working now?
I can hear you.
Good. Thank you. Thank you, Kelly, for going through that. And thank you, co-chairs and members of the committee. Sorry, I don't know what was going on earlier, but I guess I got my mic fixed. As Kelly said, my name is Rafael Robles. I'm a lead analyst here with DCBS in the research unit. And as we've seen from her presentation, we do see both in this data and what many people have probably felt just in their own experiences, trouble getting appointments, especially early on in a process. It's been taking a little bit longer. So we wanted to look at some reasons why, and one of the main components was to look at the supply and demand of providers and the amount of claims we need within the system. So we first looked at was the number of workers' compensation serving physicians or providers overall. So these are unique providers that are associated with any claim in the 2010 to 24 time span based on our medical billing data. And when we compare that to just Oregon's population growth over that time period, we see that the number of workers' comp serving physicians and chiropractors per capita has decreased. For physicians, this has been about a 24% decrease since 2010. And for chiropractors, it's a little harder to see because it's a smaller number there. It's about 28.5% in the blue. On the other hand, though, we've seen major increases in the amount of physicians associates and nurse practitioners within the system. Physicians associates specifically have about doubled since 2010. And nurse practitioners have increased by about 67% in this time period. Now, the other half of this is looking at the demand in the workers' compensation system. So we're looking at the number of claims. And in general, based on our medical billing data, we've seen a decrease in the number of claims in our sample, at least. These counts are likely low, as Kelly mentioned. These are not all-inclusive, not everything is reported, and this is also based only on claims that have a individual provider associated with them. And what I mean by that is there were some claims that are submitted that are billed to or billed by an organization, an entity. So we don't know who the individual provider was, so we couldn't categorize them, so they were not included here. Between 2010 and 2024, we see about a 31.2% decrease in the number of total claims submitted. When we split that by urban versus rural area, we see that these drops are significant in both urban and rural. Slightly higher in urban, but it's a pretty small difference, 31.6% decrease versus 29.8% decrease. So when we combine that, we see that although we have fewer physicians per capita, this drop in claims is making it so we actually have more physicians per claim available in the system across the state. That for physicians ends up being an increase in about 33.4%. We also see an increase in chiropractors, about 16%, and then major increases percentage-wise in physicians associates and nurse practitioners. That's 270% increase, so almost tripling, and 195, so about doubling in the amount of available nurse practitioners per claim. Now we can see that those numbers are still much lower than the number of physicians available, but just the increases in availability has really taken off. When we break this down by area, we see these trends are very similar, though I do note the difference in scaling on the y-axis there. In rural areas, there are fewer per claim, but the changes from 2010 to 24 are fairly consistent. It is important to note, though, that their nurse practitioners have increased much further in the rural areas in availability than they have in urban, but they have still increased quite a bit. Something else we wanted to look at is the involvement in these different provider types across the lifespan of a claim. So we looked at across the entire lifespan, all of the different services and bills provided throughout a claim, what providers were involved in each. And we see that despite the increase in availability for physicians and chiropractors, they're actually involved in fewer claims across the years. So for physicians specifically, we've seen about a 15.9% decrease in their claims involvement. It started out that they were involved at some point in the claims process in about 85% of claims, whereas now in 2024, that is just over 70%. We see that this has been heavily made up for by physicians, associates, and nurse practitioners. They, similar to Kelly's data for the first visits, are taking on a larger brunt of the claims. We see the same patterns as we separate between rural and urban areas. The drop-off in available or involved physicians is more stark in the rural areas. We see that drop is about 26% in 2010 and 2024, whereas the drop in urban areas is only about 12%. The increase in physicians associates is much larger in the rural and frontier areas. But part of that is due to just the starting point. Similarly, with the nurse practitioners, there is a large increase in the rural areas, but they started off in 2010 with more involvement from nurse practitioners, partially due to just less availability of physicians at the time. So we see that within the workers' comp system, there appears to be more providers available. per claim at least. So it's interesting in noting we do know that there is an access to care issue. It is harder for people to be seen, but it's not necessarily in the workers' comp system alone. So these providers aren't working in a vacuum. They have patients outside of the workers' comp system. So we zoomed out and just looked at Oregon in general, at the amount of providers. And when we look at the just numbers of actively practicing providers in Oregon, and these counts are based on OHA's healthcare workforce supply. This was talked briefly about by the MCO presentation a few weeks ago. We do see that per capita, we have an increased amount in physicians between 2010 and 2024. We hit a peak in around 2021 with about 370 physicians per 100,000 individuals in Oregon. And that decreased slightly since 2010, 2021, but is still an overall increase from the start of our time point. Chiropractors have seen a moderate, a very slight decline in availability. Went from 36.9 in 2018. We don't have earlier data for them in this data set, to 35.8, so very slight. But we do see nurse practitioners and physician associates increasing in availability as well. This is nice to see. Many states don't see this similar increase in growth of available providers matching the population. So that is nice in Oregon that we're seeing that. One thing I want to note on this though is we see for physicians, there's an increase overall in amount of available physicians in comparison to the population. When we looked at the workers' comp availability in comparison to population a few slides ago, we saw a decrease. And that's actually showing, like we heard, that there are fewer providers active that are willing to work in workers' compensation cases. So just an additional note here. Now, this increase is also seen, we don't have the rural-urban split, but we do have countywide split, and we see that across almost every county, we are seeing these increases. We looked at specific percent changes between 2022 and 2018 because at the time that was the data available from the healthcare workforce supply. This week, they updated that to include 2024 data, so we do have updated countywide data that you can look at if you are interested. Slight note on here. Sorry, Kelly. There are a few counties that do not have any active providers of certain types. Just examples of this, and again, 2024 data is available now, so we can have updated versions of this. But Gilliam County had 0 physicians actively practicing and registered in 2018, as well as 0 physicians associates in 2018 and 2022. Sherman County had 0 physicians in 2022. So there are a few areas where there are gaps where individuals might have to go outside of their normal area to see a particular type. But overall, there has been an increase. But again, it's not just a function of the amount of available providers. We do see that there is a lack of capacity to meet the needs. So Oregon Rural Health has an unmet healthcare needs report they released in most recently 2024. And in this report, they look at the availability of providers' appointments based on providers' FTE estimates and the amount of appointments they can have, as well as the estimated number of appointments needed for the population in the area. And this is largely based on demographics, gender and age range, and estimated appointments. And we see that across Oregon overall, we're just at the cusp of meeting capacity. But that is only if all the providers in Oregon were evenly distributed based on need. That's not the case, though. Most counties are unable to meet the capacity of the patient needs. And this is where we're largely saying this access to care issue. Though we have an increased number of providers per capita, the needs of the population are outpacing that. And this is not an exhaustive list, but a few reasons of this increase in patient demand we've seen over the years. We have an increased number of insured individuals. So the number of uninsured Oregonians has decreased from 14.6% in 2011 to 2.7%. So more Oregonians have insurance, which is nice. It means they're able to get into access affordable care, but it increases the number of appointments required. We see that Oregon's population is skewing older. The percentage of population over 65 has increased from 3.5% of the population to 19.9 in 2024. And overall, just raw numbers, this accounts to about a 63.5% increase in individuals. And the reason that's important is because individuals in the 65 and over age range require on average 4 times the number of office visits per year than individuals aged 1 to 44, and about 2 times the number of office visits for those aged 45 to 64. So as we have this skew of older individuals, we have an increase in required appointments. And then one other aspect is in 2024, we now see that over 50% of Oregonians have at least one chronic medical condition, things like diabetes, arthritis, heart disease. And chronic medical conditions are the highest or the largest reason for appointments in Oregon. So more individuals with these conditions mean more appointments needed to manage those conditions. So there's been a lot of information. So just kind of summarizing across the different findings, we do see that time to first non-emergency E&M visits has increased since 2010, specifically in those earlier areas. Fewer claimants are able to be seen within 3 days of injury across provider types. Despite this, we do see that there are more providers available per workers' compensation claim submitted. But this is not due to an increase in availability workers' comp providers, but due to a decrease in claims. So if we do see claims flatten, while we see this same trend of decreasing providers in the workers' comp system, that will change. And if claims start to increase again to pre-COVID levels, for instance, we'll see that decline sharply. We see within the system that nurse practitioners and physicians associates are increasing their involvement somewhat disproportionately. They are taking on many more workers' compensation claims, while physician involvement has decreased. And this could partially explain part of the reason to the increases in time for first appointment for PAs and NPs, as they have more appointments to manage, so it's harder for them to schedule. And then when we zoom out even more, we see that overall providers active in Oregon has outpaced population growth. However, the demand has increased even quicker, which is leading to our capacity, our inability to meet capacity across the state. As Kelly mentioned, here's some of the references from the different data sources that we used outside of our own internal data sources. And now we are available for any questions y'all may have.
Kim, anything question-wise, anything you want to add?
No questions, just it was excellent data. I mean, there was some like surprising facts in there from the data. So yeah, very appreciative of this information. Thank you.
Curious, are you available for questions after? Like, part of this is the ability to digest some of this information. I do feel strongly that I have questions, but I don't have them formulated because I want to go back through and kind of think some of this data through. So I just want to, is that an open avenue?
Absolutely.
Okay, thanks.
You know, we just hit you with 20 slides of different data points, and
yeah, and I'm supposed to know right away. Yeah, no, that's important because there are some things I want to dive a little deeper into, but I appreciate
Absolutely.
Sarah, I'm happy to get you Kelly and Raphael's contact and connect you two.
That would be great because I'm going to go through this again with a fine-tooth comb. I tried to take notes and then process, and so it will be helpful to be able to ask some follow-up questions.
To do that.
Are there any questions? I don't see any hands in the room.
We don't see anything either, Coach.
Okay, thank you, Terry. So I have the next space is for public comment. I don't have anybody that had signed up. Anybody in the room have any additional comments?
I don't have anything either. Coach.
I just feel very grateful for the incredibly necessary and spirited conversations we've had today in trying to fully understand the scope of the problem and some of the core issues. I appreciate the honesty and openness to have these difficult discussions. And I have so many notes and so much to process. And I look forward, right? This is very helpful. Like I look forward to beginning to sift through and start to have meaningful discussions around solutions. So
And co-chairs, we have another provider that will present at the July 25th meeting. It's a nurse practitioner from Southern Oregon. So
fantastic.
Excellent.
Kim, do you have anything you want to add or bring up before I potentially adjourn us 15 minutes early?
No, there, like you said, there's a lot to digest. And it was, yeah, like very eye-opening and just need to kind of reflect and think about some of these things. But I do like the some of the points about, need to get creative and it's just we have this really great opportunity to make some changes, hopefully. And hopefully we can make some things to make things more streamlined and simplified. I like those points as well.
Co-chair, I do see a hand up from Elaine Schooler from SAFE.
Yeah, please go ahead.
Hi, good morning. Elaine Schooler with Safe Corporation. This was a fantastic discussion. I really appreciate all the comments from the presenters. And as many of the comments from Dr. Takeax and Joy's presentation centered around where injured workers are treating, and as we're doing outreach to providers, there may be an opportunity to engage with the occupational health clinics to understand their role and how they participate in the system and what need they're fulfilling, to sort of create a whole picture of where workers are treating and why, so that we can be better informed as we continue to discuss pain points and potential solutions.
That's a really good point, Elaine. There was something that kind of stuck with me during these conversations about how, we're not allowed to direct injured workers to care, right? We can't tell them where to go. But the problem is, no one's taking them. And so they kind of end up by default going to these occupational health clinics. So I think a little something just kind of was turning in my head about, well, maybe that needs to be changed. Maybe that regulation about not allowing people to direct patients to care, maybe that's one of the pinch points.
Elaine, you still have your hand up. I just want to make
Oh,
sure.
I'm so sorry.
No,
Need to
I
close
I
the icon.
don't want to stifle you or
Thank
cut you
you.
off. And so yeah.
No, I appreciate it. I
Mhm.
agree. I think there are lots of different reasons and potential solutions here, and I really appreciate the conversation we're having. Thank you.
Thank you, everyone. Joy, is that a hand? You're on mute, if so. No. Does anybody else see that hand? I saw a hand.
Your hand is closed? Yeah. Oh, did I just close it? You must have, here, you can come in here.
Oh, there we go.
Oh, no, you're still on it. There you go.
I think she's trying to close out.
Yeah, I think it's just technical stuff. So,
Alright,
I'm gonna-
You're here.
Got it? Can you hear her?
yes.
Okay, yes. So I just
Oh, okay. There was a question. Great.
Yes. No, I just wanted to put it out there, that it's, some of the adjusters out there are very nice and, it's very nice to work with them. And when we hear, they say, oh, thank you so much for taking these patients, it has been very difficult for the patient to find a doctor. So we just hear a lot, just saying thank you to Dr. Takeax for taking this patient. So, we try really hard. And like I said, it's difficult out there to work with adjusters, but everybody I know out there, all the names I see on here, they're all very nice, and it's nice to work with them, and so just wanted to put it out there. But there are some, that it's difficult out there also to work with them.
Thank you. I appreciate that information. Terry, do you have anything else?
Yeah, and from Elaine's recommendation, I will reach out to Ahmed Clinic and see if I can get an Ahmed provider into one of our meetings, okay?
Okay. If nothing else, I'm gonna adjourn us at 10:50. Sound good?
Great,
Sounds
thank you,
good.
everyone.
Thank you.
Thanks, everyone.
Ben. James.